Hey guys, this is our attempt to reach more of you with some videos for, say, night shift or weekends or whatever. So this will be the first of our Survivor series for the PEA or Asystole algorithm. Not a lot of visuals in this one, so if you look at the PDF that's in the same folder, you can print that out or put it up on the screen as you're listening to me. There won't be a lot of things for me to show you. So, and you're going to see me looking down reading, so bear with me. First off, for PEA, what does PEA stand for? It stands for pulseless electrical activity. That's when you see an EKG on the rhythm strip, but there's no accompanying ventricular response. So essentially there's electrical activity, but no blood pressure associated with it. So the patient's dead. And obviously you won't find a pulse anywhere, and you can see it. It'll look like sinus rhythm, tachycardia, or even bradycardia. It doesn't need to be a specific rate or rhythm look. Obviously asystole is even worse. That means they're really dead. There's no electroactivity, there's no blood pressure, there's nothing. Asystole is kind of the tail end of a patient dying. The ones you see found down in the field for, a half hour, or even longer. They usually have an underlying cause, PEA and or asystole. And the most common causes for those are those H's and T's, which you've heard about all the time. So you obviously, if you have time or while you're coding this patient as you would routinely code anyone, you want to be thinking about the H's and T's and what's going on and how could you possibly treat them. So first we'll talk about the H's. First up is hypovolemia. Hypovolemia means they're down on volume, so you give them volume back. Colloids, hydrocolloids, LR, saline, blood, whatever they need. And obviously during that time you're coding them with your routine CPR and stuff like that, which we'll talk about in a little bit. Hypoxia. They're not breathing very well. Their oxygen level is not high enough. They need more O2. They need more help breathing. So you're going to treat that with things like bagging them, increased oxygen. If they can breathe on their own, supporting them with even still bagging or BiPAP, CPAP, high flow, non-rebreather, whatever works. Hydrogen ion, i.e. acidosis. They're acidotic for some reason. So things you can do to help with that is help them breathe better as well, because breathing better can help blow off acid, i.e. carbon dioxide. Or you would treat it with something like sodium bicarbonate to help with a metabolic acidosis. Next up would be hypo and hyperkalemia. This one is a little bit more complicated. For hypokalemia, obviously you're going to treat it. You're going to give it orally, IV. Being a code situation, they probably can't tolerate it orally, so you want to give it IV. However, potassium IV is a slow infusion, so that's not going to fix itself very quickly. For hyperkalemia, there's a number of treatments, and we see it here all the time. First up, as a temporizing measure, temporizing as it sounds or as it means is just it works for a little while. One of the gold standards we do here is the insulin in D50. So usually it's 10 of insulin IV and 1 amp or 25 grams of D50. Now, things to consider. Make sure your IV is decent first, and you always want to push the D50 first. I'd rather have your IV blow pushing D50 than pushing the insulin first and then unable to give the D50. And the way that works is the potassium shocks the potassium from the serum into the cells for a while, and then the D50 protects the body from the effects of the insulin on blood sugar, of course. Again, temporary. Also temporary treatments are things like calcium as well. That can have the same similar effect as the insulin does. More permanent ways to lower that potassium are things that actually get it out of your system, like dialysis. That would be an extreme temporary or a permanent measure, but sometimes you got to do what you got to do. Other things you can do is diurese that potassium out of them with things like Lasix, or you can poop it out of them with things like lactulose. K-oxalate is, of course, the gold standard for getting a person to poop out their K. However, more and more, especially at Hopkins, we don't give it anymore because it can cause some gut ischemia. And a lot of our folks have gut issues to begin with, so usually is avoided nowadays. Last H is hypothermia. If they're cold, you got to warm them up. There's an old saying in the emergency room world, they're not dead until they're warm and dead. So warm them up. You never know what might happen. Next up would be the T's. First up would be toxins, drug overdose. Not necessarily bad drugs. Sometimes it's an overdose of their beta blockers, or they took too many of something. But obviously in our patient population, we see a lot of the standard overdoses. They've taken too many opioids. So when you're looking at the potential drugs they may have taken, you want to think about the reversal agents. Obviously for opioids, it's Narcan. If it's for things like Ativan, it's flumazenil. We don't give that as much, but Narcan we give all the time. Important thing to consider if you're giving Narcan is often the effect of the opioid they take will be longer than the dose of the Narcan we give them. So a second dose of Narcan or a drip may be necessary. Tamponade, cardiac tamponade. The heart sits in a sac called the pericardial sac. There's a small amount of fluid for lubrication purposes in that pericardial sac all the time. Sometimes from infection, from bleeding, from whatever, too much fluid accumulates around that, in the sac around the heart, and compresses the heart and prevents it from beating properly. So the way to fix that is a pericardial centesis. Drop a needle in there, pull out the whatever is causing that tamponade. Tension pneumothorax shifts the intrathoracic structure and causes all sorts of pressure changes and almost tamponades the heart in a similar way. So the only real way to fix that is a needle decompression. Next up is thrombosis. There's two of them, cardiac and pulmonary. Cardiac, obviously they have a clot in their coronary arteries somewhere. One way to fix that is to push something like TPA. However, being in a larger hospital center, what we're going to try to do is get them to cath lab. So you support them best you can, heparinize them, get them off to the cath lab, and then hopefully they can get that clot out. Another one is the other thrombosis is a PE, which we also see all the time. And the gold standard treatment for that is also TPA. Obviously, you could give that, or they could be sent somewhere for that to be given, but all these things you just need to consider while you're coding the patient. Sometimes it's academic, sometimes it actually is used, or it's something in a preventative measure. If you have a patient who is hyperkalemic and you don't treat that K sooner rather than later, you might see a PEA arrest on this patient. So things to consider if you're starting to see a creeping up K, a creeping down fluid volume state, all things that just academically you can think of to help keep our patients healthy. Real quick, just to finish up, medications used if you're coding a patient in PEA and asystole. Gold standard med is vasopressors, like epinephrine. 1 milligram is in a 110 cc vial Bristojet push drugs. Push that. You're going to do CPR, high quality CPR, every 3 to 5 minutes. You're going to give more epi and just keep giving CPR. Atropine is not used as much anymore. Pretty much it's just epi and CPR, and obviously ambu bag, intubating them, whatever is needed. Do you shock asystole or PEA? And the answer is no, because asystole, there's no rhythm to reorganize into a healthy rhythm, and PEA already has a rhythm. It's just not helping the heart because the heart's not pumping. That's it pretty much for my little presentation for this part. I'm going to read you some questions, but the questions will also be provided in the file. What we ask is that you write down the answers and get them back to one of us so that we can give you credit for watching this video. And thank you for watching the video and dealing with me. First question is, what is an important consideration to remember when giving Narcan? What is an important consideration to remember when giving Narcan? Next question. What is the first and really only drug to use if you're coding a patient for PEA or asystole? What is the first and really only drug to use if you're coding a patient in PEA or asystole? What is one temporary treatment of hyperkalemia and one more permanent or longer treatment for treating hyperkalemia? So I'm looking for, in hyperkalemia, I'm looking for one temporary and one more permanent treatment. 2 total answers there. And then last, do you shock PEA systole? Why or why not? Okay, guys, thanks.